Hi, my name is Dr. Luisa Kimeli. I'm a psychologist and the director of the Emotional Health CBT Clinic in Montreal. And today I'm here to talk to you about panic disorder. So I'll tell you a little bit about what is panic, how common it is, some treatment components, as well as a few tips. So what is panic disorder? Well, it's the fear of having a panic attack. So we need to first define what is a panic attack. So it's when unexpectedly you begin to experience a whole bunch of physical symptoms. Well, a whole bunch, at least four of the following. So you can have changes in your breathing. So you feel like all of a sudden you can't catch your breath. Your chest is getting tight. Your heart is racing. You can have even chest pain. You have feeling of choking or like your throat is closing. You also have symptoms in terms of perception, so like things are unreal or strange. There can be sweating, feeling dizzy, hot or cold, numbness in the hands or feet or tingling sensations, as well as digestive sensations, so some nausea or just like feeling unwell in that area. And oftentimes it comes with fear. And here we're talking about, fear of dying, fear of having a heart attack, fear of going crazy. And you can understand how this would happen, if you're just going about your day like any normal day. You're at your desk, you're in your car, on the couch, or sometimes even sleeping. Um, and all of a sudden, your heart is beating really fast and you feel strange sensations in your chest and you feel like you can't breathe. You understand how that would be a really scary experience, and that there would be fear involved in that. Like in particular, because it's out of the blue and there's no explanation for it, right? Because if you're going to the gym or you're running after the bus and all of it, and at that point your heart beats fast and you feel like you're out of breath and all of those things, you're pretty much expecting it because you're running for the bus. So this is like having a bunch of physical sensations, but there's really no clear explanation as to what is happening. Because otherwise, like I said, you just attribute it to something and it wouldn't be all that scary at all. So a panic attack really will last, on average, like 15, 20 minutes, but could be 10. So it could be, anywhere from like a minute to an hour, and the peak can be reached like really quickly, or you could have like a perfect U shape, inverted U, sorry. And it's really a rush of fear. It's the same or similar physical reaction that you would have if a bear was coming at you, or a car, and you needed to react right there and then. It's that kind of flooding fear reaction. And so then what is a panic disorder? Well, it's when you start to fear, like you've had more than one panic attack and now you're thinking like, oh my God, I hope I don't have a panic attack again. It's so awful. And it could lead to a heart attack, or it could have some very serious consequences. So in terms of actual definition, it's like you've had panic attacks, and for now a minimum of 1 month, you've either worried about having a panic attack or its consequences, so you're really preoccupied by that, or you've begun a bunch of avoidance behaviors to avoid having a panic attack. Most often people have both. So you don't want to have another panic attack, you're thinking about it an awful lot, and you're also doing a lot to try to not have one. And so here we're talking about an avoidance of physical sensations that are linked to panic. So, anything that can trigger physical sensations. So, exercise, coffee, alcohol, spicy food, sex, like anything that would start a physiological reaction, because then you're afraid that it's going to go out of control and lead into a panic attack that then you won't be able to control. There's often safe objects involved to, when the person is trying to prevent having another panic attack. So, there's safe places, safe people, safe objects, some to provide reassurance. So a good example of that is how people who experience that choking sensation will carry with them a bottle of water or some, like, whatever liquid, so that basically they can drink to show to themselves that, no, look, it's open. So it's like a way to calm down and avoid the sensation snowballing into a full panic attack. Some people will be checking to make sure their pulse is okay. So there's all of these kinds of things. So what happens really is you have a panic attack, which is as if there was a bear, and it creates this strong physiological reaction. But now you get to be afraid of that reaction per se, because there is no bear, and now you're just afraid that you're going to experience that. And oftentimes it can lead to the development of agoraphobia. So what is agoraphobia? It's really a fear of situations that are hard to escape. It doesn't have to be, it's not claustrophobia. It's not necessarily, it can be an enclosed space from which it's hard to escape. So, a plane, a train, a bus, like, you have to, like if you take the metro, you can't get out anytime you want. You have to wait until the next station. So, like, it's not immediate. So it can be things like crowds, lineups, meetings, movies. So that's what I was saying. It doesn't have to be that leaving the situation is difficult necessarily physically, but it can also be socially. So, people will start to avoid or fear a meeting, like especially if they have to present, let's say, where it's difficult in the middle of it to say, okay, I'm sorry, I need to leave. So it could be because of social implications or consequences that make it difficult to leave, or physical place where it's difficult to leave. People will also, if they're really concerned about their health, like they think that there is something wrong with their heart. For instance, if a lot of the sensations is palpitations, chest tightness, or even if it's not related to the heart, if people really think there's something wrong with me physiologically, and I've got this condition that's causing this that we can't figure out, I better stay within a certain radius of a hospital, so that when it happens and it leads to these disastrous consequences, I can at least get the help that I need. So for some people, the anxiety is really about getting out of that radius. So, going to the country, for instance, as opposed to staying within the city. And this is also how, unfortunately, panic becomes debilitating, because people start to avoid, and then they get to be more and more and more and more restricted and have less pleasure, and all of those things that make life worthwhile. So In terms of statistics, it's about 3.5% people that will experience a panic disorder, and most are women, and it often begins in early adulthood. And there is a cost because, as you can imagine, people will, there's a cost in suffering for sure for the people experiencing it, as well as their loved ones. But also in terms of sick days that people will take from work, the visits to the GP, or even to the ER. Some people are lucky in that they go to the ER or they speak to their GP and they get diagnosed with a panic disorder and they get referred to psychologists. And that's really what is needed. But some people just get told that there is nothing wrong with them physically and sent home with a clean bill of health. But that doesn't necessarily help people very much because there's still sort of that question of then why is it happening, and maybe the doctor or maybe the tests didn't detect what I really have, and I really have a condition that is dangerous. It's debilitating when associated with agoraphobia, especially. It's exhausting. The amount of energy that is expanded both in terms of trying to prevent having a panic attack, thinking about it all the time, monitoring bodily sensations. So it's always there in people's minds. Then it's exhausting to have the panic attack, especially if it's a series of panic attacks. Like sometimes people will say it lasts all day. Now it probably doesn't, it's more likely, physiologically to be a series of panic attacks. But yeah, you can imagine the amount of energy that it takes. It can be, it can then lead to other problems as well. So either alcohol use, social withdrawal, depression. Like I was saying before, people's worlds, especially if they have agoraphobia as well, people's worlds get smaller and smaller, and it really, interferes with them doing things that they want to do. Like, people will get to be impaired in their work, like refusing maybe travel that would be really good for them, or, not present at a meeting at their schools. They'll try to avoid going to their schools, to their children's activities, because again, leaving might be a little bit difficult. So you can see that there's a high cost to panic disorder. So what causes it? There's biological factors. Obviously, it is a physiological response. It's real. Like the person is really sweating, their heart is really pumping hard. It's not in their head. They're not making up the physiological reaction. But in terms of like predisposition, there is also there is a genetic component, like when they do twin studies to see, if like you compare identical twins to non-identical, and that were separated, so they're growing up in a different environment. So you're taking out the effect of the environment, and they're looking at the concordance. If one twin has a panic disorder, what's the likelihood that the other twin has it as well? And what they find is that, in fact, there is more of a correlation with identical twins. So it shows that there is a genetic component. And also, if you look at relatives who have a panic disorder, the relatives of someone who has a panic disorder are also more likely to suffer from a panic disorder. As always, none of the genetic biological factors are 100% of an explanation. You might not have anyone in your family that has ever had a panic disorder and have one, and the reverse might be true as well. It's just, one of the many factors that can contribute. But most importantly, at least from our perspective as psychologists, is that to panic, you really need two things. You need, yes, the physiology, the physical sensations, but you also need a catastrophic interpretation of those sensations, because if you're going to the gym and your heart is pumping fast and you're breathing quickly and you're sweating and, you know, all the same things are happening, and you say, hey, look at me, I'm working out, I'm doing myself some good, you're not going to panic. Same thing, you know, if your doctor, like if you had a surgery of some sort and the doctor said, oh, well, no, it's successful if you experience those symptoms. It could be out of the blue and you would have the same thing happening as in a panic attack in terms of physiology, but you would not have the fear that goes with it. So the interpretation is really, really important, and it's key because that's where we can intervene. So in terms of the treatment, there's relaxation, cognitive restructuring, exposure, medication. I will go through all of those. Relaxation can be an important component because oftentimes people, even though it's not a one-on-one, it's not like, you know, something stressful happens and you got a panic attack, like it's not a clear trigger. Oftentimes when I see people in my office, there's been a lot that they've been dealing with, like a lot of stress and you know, if your base stress level is a lot lower, you are less likely to have panic attacks. So just, you know, try to make sure, I mean, you want to go out of your comfort zone and do things that you want to experience some stress. If you have none, it's not a good thing either. But it's about finding that right middle and having some strategies to manage the stress. So here we're talking about, you know, sort of the regular things that we recommend. So deep breathing, paced breathing, so that's like counting with the breath. Passive relaxation, where you're just running yourself through the different body parts and relaxing those areas. So, you know, you go through your hands, just relax your hands, and you're just doing it by focusing on that area. Versus active relaxation, which is about putting tension in a certain area and then releasing it slowly and noticing the difference. And then, you know, things that you can do, like just walking, being more mindful, visualizing nice images, places that you like to go, having those, like bringing those up to your mind. I mean, there's, you know, I could talk probably for hours about relaxation, but the point here is just if you suffer from panic, to, you know, try to bring down your stress level a little bit, or increase, even better yet, increase stress management. Like, you want to have stress in your life because it means you're doing something, but make sure you have, you know, things in place that allow you to manage that. So one of the powerful component of the treatment for panic is psychoeducation about what is actually happening when someone is having a panic attack. It's about learning that it's not dangerous, actually. So I put here an image of the pedal and the brake because I think it's a good analogy for the two branches of the autonomic nervous system that get activated. And also because there's an example that I like to give sometimes that relates to the car. So really, what happens when you have a panic attack is that the sympathetic branch of the autonomic nervous system is activated. So you're pressing on the gas, like all of a sudden. And what that does is it starts an adrenaline response. And so picture there's a bear. So you're either going to fight or you're going to flight, right? So it's that fight or flight response. And so what do you need for that? Well, you need the blood to go to your major muscle groups. So you need to have your heart pump really hard. You need fast breathing. Like, just, visualize or imagine yourself like running away from a bear. Okay, so that's what you need, right? So as the blood is going to your major muscles, it's draining a little bit from your extremities, so you can have, the tingling sensation or the sweating sensation, like those kinds of things. It's draining away from your digestive system, because like that's not a priority right now. So you can have, that nausea, those kinds of sensations. Draining a little bit from the brain, like you need acuity, but at the same time, again, major muscles being priorities, so you can have like things looking very different, because it's like hyper focus, and like there's changes there to allow you to run away. And so you really have pretty much all of those. Can I go? Yeah. So you pretty much have all of those symptoms that we were talking about before. So, the breathing changes, like it's, increases in speed, the heart increases in speed, the chest is going to feel a little bit different. Since, like, as I said before, that the fact that digestion is not a priority means like different sensations along the way as well. Because your blood, your vessels are constricting in a different way, you can have hot and cold as well. So that's really the sympathetic branch. It's like, okay, like, need to act now. So it's very intense, and that's the accelerator. But our body is well made, and so as soon as the sympathetic branch kicks in and causes all these things, your body pushes on the brake to say, okay, we need to get back to our regular state, to homeostasis. So as soon as you start the accelerator, the brake comes in, and it will restore all the physiological functions back to their baseline. And an example that I use as well for that is that relates is if you've driven for a long time and you've driven a lot on the highway, you probably, or even in the city, you probably had that experience where all of a sudden, like, everything's going really quick, and all of a sudden, bang, traffic stops. And if you've had the experience of braking at the last minute, really, your heart is pumping like it's gonna come out of your chest. You're shaking like a leaf. Your breathing is different. You just experienced the activation of the sympathetic branch of the autonomic nervous system. But if you stopped on time, you look in your mirror to make sure that the other people are stopping on time too behind you, and you realize, yeah, okay, everything is good. Within maybe 5 minutes or 10 minutes at the most, you're back to normal. I mean, you might still feel a little bit shaken by the experience, but physiologically, as intense as it went right back to normal. And in a way, that's what a panic attack is. It's a false alarm of the autonomic nervous system, where bang, the sympathetic branch is activated. It's scary because you don't have an emergency situation that's clear. You're just not doing anything in particular, and all of a sudden it happens. But if you're able to let it go and say, okay, like, it's fine, things will go back to normal. When people say, I panicked all day, what it really is that they kept thinking about it, like, oh my God, I hope I don't have a panic attack. So it's like keeping that state of high alert, as if I was still afraid that there would be other cars behind me as well. So it's really, just back here. So it's really normal. Like it's the sympathetic branch that's activated. It brings out all of these symptoms, and then it returns to normal. So it's not, there's nothing dangerous about it, is the main point. It's not harmful. It's no different, you know, if you think your heart is good enough to go for a little run, well, it's good enough to have as many panic attacks as you can produce. It's not harmful. It's really, yeah. So the common faulty thought is, you know, I'm going to go crazy, I will faint, I will have a heart attack, this is never going to stop. And this is what maintains the panic and panic disorder. If you had the sensations and knew that it wasn't dangerous, then you wouldn't, you know, you'd have a panic attack, but you wouldn't have a panic disorder because you wouldn't fear it. And I think that's an important point that I wanted to make earlier, but I may as well make it now. That like a panic disorder is really a fear of that physiological reaction. And, you know, because these sensations indicate that, you know, you're going to die. It's a fear of panic attacks. So it's not, and it's really about, you know, panic attacks that occur just like that, just out of the blue. So it's not in reaction to something, like, you know, because people will say, oh, I had a panic attack, you know, in the exam, or I had a panic attack, you know, like in this situation. But if it's, you know, let's say that it happens only in social situations, then what you really have is social anxiety. Or if it happens during a performance only and you're afraid of giving performances, well, then it's performance anxiety. Or in the context right now of COVID, if someone is afraid that they caught the virus, and that, you know, there could be like grave consequences because of that, then we're talking about illness anxiety disorder, which is next week's talk. So what we're talking about here is really thoughts about that reaction, that physiological reaction, and not knowing where it's going to lead and not wanting to have this physiological reaction. And that's really what maintains the symptoms of panic and panic disorder. So it's really the difference of, you know, having sensations and being able to say, okay, it's anxiety, it will pass, versus, you know, I can't have these sensations, what's wrong with me, this is terrible. All you're doing in the second cycle is you're increasing anxiety, and because they're anxiety symptoms, you're triggering the autonomic nervous system again and again. There's, you know, in terms of cognitive biases, there's what we call hypervigilance. So, you know, monitoring, like how is your heart beating? How's your breathing rate? Are you feeling dizzy? And all of this because you're trying to gauge, am I about to have a panic attack? Am I not? How do I, you know, part of preventing something from happening out of control is to detect it from the start. So you're like sensing these physiological reaction a lot more than someone without a panic disorder would. And there's huge variation. I mean, if you think, well, first of all, I mean, go to the pharmacy and go to the, you know, digestive aisle or to, you know, different aisles. I mean, people have all kinds of, you know, physical sensations, but also like just normal variation during the day. So if you eat a big meal or even a smaller one. I mean, it's a question of amount, but you eat a meal and your blood pressure goes down a little bit, and your heart can, will go along with that. Like there is a postprandial normal reaction that happens. There's your circadian rhythm. Your body temperature doesn't stay exactly precisely the same throughout the day. Like not that there's all of these variations in physiology that occur. And most of us who don't really are not worried about having a panic attack or any particular illness don't notice them at all. They don't get caught into our radar. But in panic, there's that hypervigilance to sensations. There's also the catastrophic interpretation of, if I can't breathe, like if I feel like I can't breathe, I'm going to stop breathing and I'm going to die. If my heart beats really quickly and doesn't, it's at some point going to stop, I'm going to have a heart attack and I'm going to die. I could end up going crazy with all of these strange sensations, and I'm losing my mind. So it's the interpretation again of the sensations. In terms of behaviors, there's checking, seeking reassurance, safety behaviors. So like I mentioned before, as an example, like carrying water to prove oneself that you can swallow, so your throat is not closed. I like this little cartoon that said, I checked my symptoms on the internet and I think I might be dead. If you go on the internet, there's a lot of, you can diagnose so many things with just a few symptoms that are really dramatic, ailments. So it's important to really understand that, okay, a panic attack is just the brake going on. It's the sympathetic branch of the nervous system that gets activated and it creates these symptoms. It's just, so you didn't plan to go to the gym and have a workout. You were sitting at your desk not wanting a workout, but you got one. It's anxiety. It's not dangerous at all. As soon as the gas is activated, the brake is activated, and if you let it be, it will pass. It will pass for sure. And it's unpleasant, though. I think that needs to be acknowledged. Very unpleasant. But, it's okay, though. And what I recommend to people is, in your iPhone or on a card to write down these helpful statements, because it's easy when you're not having a panic attack to think in a very rational way. But when you are experiencing a panic attack, it's a lot harder. So to just write to yourself, okay, my heart is beating fast because of the fight and flight response. It's not, there's nothing wrong with my heart. Whatever your own personal negative thoughts are, or catastrophic thoughts are, try to generate some that are more realistic and helpful and have those with you. So when you are having a panic attack, you can access those. And, really the bottom line is that, yeah, it's not because they happen with no explanation out of the blue. Can happen, that you wake up during the night or in the morning in a panic attack. It doesn't mean anything. It doesn't mean anything catastrophic other than you're having a panic attack, which is an anxiety response. So, to try to correct these things. And also, if you feel like you can't breathe, you're probably hyperventilating. That's part of the fight or flight response is to breathe a lot more quickly. And so what you want to do there is slow down your breathing. And I'm mentioning this because it's easy when you feel like you're not getting enough air to want to take in more. So it's about here it's about, you know, feeling versus like trying to be rational. And it's like, okay, I feel like I'm not getting enough, but I know I'm getting too much. I need to slow down my breathing. That will make a difference in terms of having your bodily functions return to normal. And for agoraphobia, to recognize that, you know, a panic attack is really your body producing these physiological symptoms, and it doesn't matter really where you are. So, you know, to try to not avoid situations as much as possible. Now, the real meat of the treatment is interoceptive exposure. And that's really when, I mean, after everything that we discussed regarding cognitive restructuring, at this point, you're probably thinking, okay, I get it. These symptoms, you know, when I panic, are not dangerous. But I still experience them as, you know, really scary. It's like you've associated with repetition, having the sensations and a response of fear. You know, these catastrophic thoughts, but also like just physically. Like an analogy that I like to give is, you know, I was fearful of having blood taken, but it was just a fear. Like that's not logical, and it's a good example, I think, because most people will say, I should have my blood tested. It's good for me. Nothing bad could happen. You know, there's no like logically this is a great thing to do. But as you're, you know, walking in the clinic towards you know, towards the test, the blood test, your anxiety just goes up and up. And it's not, it's like you'd say logically I want to do this. Like there's no you know, argument that I'm making against it. It's just fear at that point. It's an association between, you know, a specific thing and a fear response. So how do we deal with that? There's only one way, and it's through exposure. And I put here a photo of my cat Molly just because I like to give the example of a fear of cats, because it's something that's concrete. Because for panic, we're talking about physical sensations, which is a lot less concrete. So if someone was fearful of cats, had a phobia of cats, you know, how do you think you would resolve that? Well, you would have the cat, you know, stand at one end of the room, and you'd have the person stand at the other end of the room until they were, well, not the cat, but until the person was calm, and said, "It's okay. At this distance, I'm good. I can stay here. You know, I don't have to go away. I'm fine." Okay. And then you'd say, well, can you take maybe just one step closer to the cat? Some anxiety, but then, okay, like, you know, over some time, the anxiety decreases until they can be, you know, a little bit closer to the cat, and all is good. And you would proceed that way, you know, step by step, until the person is, you know, right next to the cat, but not touching it. And, you know, until they're okay with that. And then, you know, get them to touch the cat and just be okay with that, you know, just touching it. So it's like a systematic exposure to the cat. It's really the only way that I mean, the other way would be, you know, throw the cat and the person in the closet, lock the closet, but that's not very appealing for anybody, including the cat. So here, what you have is a fear of physical sensations. So it's the same thing. What you want to do is slowly get exposed to the physical sensations until you're comfortable with them. Now, I've never had a client tell me this, but I always imagine this is what they're thinking, because this is what I would be thinking if I was in their seat, is like, hello, I'm exposed to physical sensations all the time. That's why I'm here, because I have panic attacks all day long. Or, you know, like, it's not like I'm not exposed already. Like, is that really your plan for treatment? And it is, because when you say that you're being exposed, it's not what we mean by exposure. It's as if you're afraid of the cat, and so what you do all day long is you run up to the cat and run away as fast as you can. You run up to the cat and you run away as fast as you can, and that's what you're doing all day long. Because really, when you have a panic attack, when you have these physiological sensations, you think, oh my god, like, let me get some water, let me get out of here, let me like distract myself, la 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 la. You're like, you're not wanting to deal with these physical sensations, right? Like they need to go away ASAP. And you'll do all sorts of things. Or if you have a prescription for benzodiazepines, you might just, you know, take an Ativan. You're not being exposed. You're you know, you're going there, but then you're running away. So you're not staying with it, which is very different. And it's also not done in a gradual way, because the panic attack just comes and you run away. The panic attack just comes and you run away. So what we want to do is do this gradually. And it really works. I mean, out of all psychological interventions or techniques, interoceptive exposure is like, I believe, I could be wrong, but I believe that it's the one that's been shown to be most effective. Like, it really works. So the idea here is we want to replicate the symptoms that bother you the most when you have a panic attack. And, you know, we have different techniques that can replicate that. So for instance, if someone, you know, if the thing that bothers you most is like, I can't breathe, like that's what happens in a panic attack, then what we might do is have you hyperventilate. So that would be something like either like, you know, breathing really fast for, you know, 10 seconds, 15 seconds. We can slowly increase the rate. Or if it's, you know, tightness, like you can't breathe, but tightness in your chest also, we might have you breathe through a straw. So you feel like there's, you know, less air coming in, and it also tightens the chest. If it's more the dizziness, we can have you spin in a chair. Now, I mean, I can't speak for all psychologists, but I always do it with my clients as solidarity, and also to gauge a little bit of, okay, yeah, that's, you know, 30 seconds of hyperventilation. This is how you feel. And so here the idea is to try to replicate as much as possible the quality of what you experience when you have a panic attack. So of course we're not, you know, creating a full-fledged, you know, 10 on 10 worst panic attack that you've ever had. What we want to do, like I mentioned with the cat, is do it gradually. So as long as we're getting similar sensations and some anxiety, and here we're hoping for maybe 6 on 10 in terms of anxiety. Again, you know, we're not going for the 10 on 10. So we'll elicit the sensations. It's going to elicit some anxiety, and that's okay. And that's what we want, because then with repetition, the anxiety is going to go down until you can have that level of sensations and be okay with it, just like we would with the cat. And then we'll, amplify the sensations a little bit, but it's okay, because at that point you're starting, you're still starting from zero from an anxiety perspective, right? So, like the same way with the cat, like if you're, your anxiety might be like a 8 on 10 when you're far away. But by the time that we're getting you to pet it, it's like, okay, petting it is, a 6 on 10, but it's like a staircase that, you're taking off a step. Now there's some principles to this, so it needs to be repeated, it needs to be practiced. For it to stay. Again, if you were afraid of cats, well, it's important that, once you've mastered being with the cat, that you do it repeatedly. If you do it just once, it might not stay. So it's the same thing with this. And it's important that you really focus on, okay, I'm having these sensations, like focus on the sensations, to be okay with the sensations without distracting yourself, without saying, well, it's okay because I'm close to the hospital, it's okay because I'm with someone, it's okay, like you're just really working with the sensations. Because when you say it's okay, it's a little bit like avoidance, like running away from the cat. And so, this graph really shows how systematic desensitization works, which is what we'd be doing here, like systematically desensitizing you to the physiological sensations that you fear. And so what you see happens is that, the dotted line shows what you do probably on your own, where you get out of it, like you do anything you can to make the panic attack go away, like that's your focus. And so you never really get to see that actually, if you stay with it fully and you don't try to make it go away, but you just stay with the symptoms, they go down over time. And what you'll see, the different lines are showing repetition. So you can see that, the first thing, so it's the first time, so let's say that we have you hyperventilate for 30 seconds. So the first time, your anxiety will peak higher. So you might reach like a 7 on 10 in anxiety, and it takes like half an hour to go down to baseline. So half an hour of repeating. So okay, one trial, and we do again hypervent, like, so it might take 20 times of doing it before you're at a point where you're hyperventilating for 30 seconds, you're getting these physiological sensations, but your anxiety level is now at a 1 or 2, which is what we want. That's what we want to build on. So the first time around, it might, the peak, like I said, might be 7, and it might take you half an hour to get to a 2 out of 10 of anxiety level. The second time you do it, the peak is less and you reach baseline quicker. The third time, again, the peak is less, you reach baseline quicker, until you're at a point where it's like you can hyperventilate for 30 seconds and feel the physiological sensations, but not feel anxious about it. And that's how we get you to the point where you're able to say, I can have the sensations that I so much don't want to have right now. I can have them, and it's okay. And it's the same that we would do for the agoraphobic situation. So if someone is afraid, for instance, of taking the metro, we're lucky at the clinic because we're right next to a metro station. So it's kind of convenient for people with agoraphobia. And so what we'll do is we'll go with them. So the first time, depending on the level of fear that is involved, the first time we might just go inside the station. And the next time we just go on the platform. And the next time we figure out what's a short distance, like 2 stations that are not very far, and say we're going to do 1 station. and that's it. So it's, progressive desensitization, and it really works. And at first, I mean, this is so in an ideal world, you wouldn't have safety cues because they, in some sense, allow you to avoid the anxiety a little bit. But in practice, I don't see any argument against it. If it helps you to take the metro, to have a bottle of water with you, bring the water. And then at some point, though, once you're okay taking the metro with your bottle of water, maybe you could say, okay, I'm gonna do it without. It can be sort of a way to progressively make it to where you want to be. But in general, as a theoretical principle, avoidance is what maintains anxiety. So you want to not have too much avoidance. So, an avoidance again can be like having a bottle of water, having an Ativan, having someone that you trust, not being alone. So okay to work these into your exposure, but at some point, you really need to give it up, so that you can really learn that it's okay. In terms of medication, there's two classes that are of medication that's prescribed for panic. So you have the benzodiazepines and the SSRIs, and they're very different. So the benzodiazepines are the ones that act, really quickly to decrease that physiological response, and the SSRIs are, it's the same medication that's used for many anxiety disorders, for depression. It works over time, so it might take about 4 to 6 weeks to have the full effect. So my view on it is, that if it helps to get you there, if you take an Ativan to take the metro the first time, but then the second time, or like with some practice, it allows you to say, okay, I can do this, I don't need the Ativan, then we're doing well. Like it can help you, to make something a little bit more acceptable until you master that activity. What's most effective? It's like CBT is effective, medication is effective, CBT and medication. I think it depends on severity. I think if you're lucky enough that you're seeking treatment early enough, I would say do the therapy. You might not need the medication, but if it's quite severe and debilitating, you might want to consider. So the tips. Remember that anxiety can cause a wide range of physical sensations. So, and it can be strong. And, just think again, if there was a bear, I mean, trust me, your heart would feel like it's like wanting, like it's going to come out of your chest and fall really far. They can be really, really intense, and it's anxiety. So, again, across the whole spectrum, like across the whole body. Regardless of the intensity and whether they occur out of the blue, they're really not dangerous. You're not going to die from having a panic attack. You're not going to go crazy, because that would be like having a psychotic episode, and to my knowledge, that's never been, like, it's not how it goes. It's very different. A psychotic disorder versus an anxiety disorder, like totally different. You're not going to go crazy from that experience. Fainting is very unlikely. It could happen because it's one of the responses, that evolved. Like in a very dangerous situation, you can fight, you could flight, but you could also freeze or you could faint. Like all of those things could be adaptive in their own way. So it could happen, but it's like very, very rare that someone would faint. So all in all, I mean, these things are not dangerous, and we don't want to get rid of any of these things, right? Like you want to be able to have an anxiety response if it was warranted, right? So we don't want to get rid of this. What we want to do is get rid of the association between the physical sensations and fear, because that's really what maintains the panic attack, because you're not wanting. It's the paradox in psychology, right? That if you don't want something, you're going to have it, especially when it comes to anxiety. But think of like an example that we give is, for the next 5 minutes, your task was to not think of a pink elephant. That's all you would see. And so the moment that you say, I don't want to have symptoms of panic, you might. So that's the paradox, that you have to get yourself to a point where you can say, okay, I can have these symptoms and it's fine. Like the goal is not to get rid of the symptoms, but to get rid of the catastrophic interpretation. If you feel like you're not getting enough air, you're probably hyperventilating. So it's the opposite. Like you want to slow down your breathing. And as I mentioned, to panic, you really need two things, because you're not going to have a panic attack if you don't have the two. So you need the physical. And I think, if there's a take-home message from this talk, that's the take-home message. Because if all you have is physical sensations, you can have that from going to the gym, from catching a bus, from sex, from like all sorts of things. And you don't have the catastrophic interpretation, you don't have a panic attack. If you don't have any physical sensations and you have a catastrophic thought, but there's like no physiological symptoms, you're not going to have a panic attack either. So it's really about thinking, okay, where can I intervene here? Physical sensations, are perhaps a little bit harder to control, although you could practice relaxation, decrease your stress level overall, deep breathing. So there are, certain things you could do to work on the physical sensations, but it's really the catastrophic interpretation that you want to work on. And practice having the sensations without trying to make them go away. So that's, really the exposure piece. So panic is a fear of fear. It's not wanting to have that reaction. And you can relax, use cognitive restructuring, which is, changing your thoughts around panic, and have exposure to sensations. And these are some helpful books. There's a series that's called The 10 Simple Solutions, and to a bunch of different things. And they're really good. They're, by reputable psychologists. So here we have the 10 Simple Solutions to Panic by Martin Anthony. I would highly recommend that. It's a tiny little book, but it really explains pretty much everything that I explained in this thought and in this talk, and perhaps more. And then the Anxiety and Phobia workbook is also a good reference. So that's it. Thank you very much for joining me, and I hope that you join us next week as well for the talk on health anxiety, which is in a way related but different. Thank you.